So we're here today to talk about breast cancer. And breast cancer is getting a lot of, always gets a lot of press. If you watch a football game nowadays, you can't notice, but all the pink they're wearing, breast cancer awareness. And it's a very sort of mixed signal because there's also a big push out to that screening mammography is not the best thing in the world. We're not doing a great service with breast cancer. Still, so many women are dying of it. And I'm here to set the record straight that we really are making amazing accomplishments in this field. 1 out of 8 women in this room, some of you may have already been diagnosed, but 1 out of 8 women will be diagnosed with breast cancer. Second leading cause of death, lung cancer still is the top among women. Second most common cancer. Breast cancer is a disease of getting older. Your incidence increase, but again, we see a tremendous amount of breast cancer in young women, women under 50. Everyone wants to know, am I at risk? What are my chances of developing breast cancer? And again, the age is again one of the major risk factors for it. Personal history. Is there a strong family history of breast cancer, especially if breast cancer under age 50? If you've ever had radiation, treatments with DES, which is a type of hormone replacement therapy used to help with pregnancy, genetic factors, menstrual history, all these things play a role. But I would say 90% of the women I see in my practice have no other risk factors for developing breast cancer. It just happens. What can a woman do to decrease her risk for breast cancer? Again, weight control is important, exercise is important. Breastfeeding, women who breastfeed their children have a less incidence of breast cancer. Alcohol consumption, a lot of alcohol will up your odds of developing breast cancer. If you've ever been on hormone replacement therapy or birth control pills, now we know, again, if it's a back and forth, hormone can cause breast cancer, it can't. I think the evidence is pretty strong that we're seeing a decreased incidence of breast cancer because less and less women are going on hormone replacement therapy. And having no children increases your chances. But again, every woman is at risk. What can you do? What's your health plan, your own basic health plan to try to ward off or detect breast cancer? It's going to happen, it's going to happen. So you want to detect it early. That's the secret. You want to get the breast cancer at the smallest stage, not only the tumor being the small size, but early in the history of your breast cancer, because the earlier you get it, the less chance it has spread to other organs or has gotten into your systemic system. What is breast cancer symptoms and signs? A lump in your breast. So women should be familiar with their breasts, do monthly self-examinations. A lot of women, though, have problems, have lumpy feeling breasts. They call that fibrocystic disease. It is not a precursor or increases your incidence. It's just the way your anatomy is. A thickening or swelling of the breast, nipple pain or retraction, breast skin dimpling if the skin is pulled in. These are signs you immediately need to see a physician. And a spontaneous breast discharge, again, can be other things, but again, has to be worked up and evaluated by a physician. Again, this is the whole big thing now with screening. They go back and forth starting at age 40, starting at age 50. I see no reason, if you're age 40, you need to have mammograms. If you have no family history, again, you can go a couple of years. But again, starting at age 40, it's good to get in the habit of having mammograms. Not only that, the radiologists will get to know radiologically what your breast looks like so they can pick up subtle changes year in and year out on your mammogram. A clinician's breast exam, your family doctor doing a breast exam at age 40, it's okay to skip a few years if you have a normal exam and you're not a high-risk patient. Certain women are high risk, and I'll talk about that in a little bit, need to have them done every year. And self-breast examinations, this is an easy test to do. You can do it in the shower and just get to know what your breasts feel like and notice, and it will help you notice a subtle change. And this is, again, I think this demonstrates it very well. The average lump found by a woman practicing occasional self-examination, big tumor. Average lump found by self-examination. But then if you get to average size found by first mammogram and average size felt by regular mammograms, this is what, as a clinician, you want to see. You want to see a very small tumor that we can do. All of our treatment options are available, and a woman you pick something up this small in a woman, 99% chance we're going to cure them. This is what a mammogram looks like, and again, it's confusing because women's breasts, the older you get, the younger you are, the more fibrotic or scarred your breasts look, As you get older, this is all replaced by fat, which is the darker areas. So the younger women, it's very hard to do mammograms, but again, if they detect some abnormality or difference in both breasts, this is what the radiologists are trained for. We actually have a beautiful breast imaging center here, the Norval Breast Center. Again, these radiologists are trained and retrained and certified every year that they are experts in understanding and detecting mammograms. And I think if you look, you can see these little granulars of calcification. This is what they look for. Also just subtle changes in breast to breast in the architecture. Well, this is the big problem. The mortality of breast cancer, women dying of breast cancer, has remained pretty stagnant. It is just recently we're seeing a decrease in the mortality. But the incidence is skyrocketing. And why is this? And some people blame because we're picking up, so many women now are getting mammograms, we're picking up so much more breast cancer. But there is something in the air or the water, it's out there. Breast cancer is of epidemic proportions. Breast cancer starts in the cells that give rise to the milk for the babies. Breasts usually consist of fatty tissue and those ductal cells, which when are stimulated by the estrogen, progesterone, give rise to a proliferation which causes milk to be produced for the babies. These are the cells that as a woman ages start turning a little ugly, start getting a little bigger, more nuclei, the centers of them become darker. This is called DCIS, or ductal carcinoma in situ. This we diagnose a lot nowadays. This is an early precursor of invasive breast cancer. This is extremely curable because it doesn't have time to get into your bloodstream or your lymphatics. This is just breast cancer under the microscope. You take this out, we give radiation to the breast generally, and your cure rate is usually 100%. I always tell patients that DCIS, or ductal carcinoma in situ, is like having weeds in your garden, but you have such a big wall surrounding your garden. Can't get into your neighbor's garden, can't get into your bloodstream, or get anywhere else in your body. But if this is left alone and not detected, it's going to form full-blown ductal carcinoma, infiltrating ductal carcinoma, which is the real killer. This is what a breast cancer looks like. This is a breast tissue, mostly fatty tissue, and you have in the middle this white, we call it sclerotic. It's very fibrotic. If you cut a knife through it, it's gritty. It feels very hard. And that's very interesting, and I'll show you that in a minute. And again, but you can see how the cancer infiltrates out into the fatty tissue, okay? That's why cancer is called the crab, because the crab legs form out into streams into the surrounding tissue. If you look under a microscope, fat cells are these clear cells that look like this. The cancer are the darker cells, and streaming, no organization to them. They're not forming any ducts or glands. They're just streaming out into the tissue. Interesting enough, the grittiness is not the cancer, but it's this background, this pink hyalinized tissue, which is fibrous tissue. So the cancer actually uses the body's own cells, normal cells, to support itself. These cancer cells grow and survive and get their blood supply from this fibrous tissue. So the cancer is a very smart organism. It uses the body's own natural or normal cells to feed itself and grow. And this is just a little higher powered. You can see some of these, this is what a gland looks like, and some of these cells are trying to form glands. It's trying to mimic the original cells it came from, but it just doesn't have the genetic intelligence to do that. So these are just growing out of control, reproducing, and spreading. What are the heavy guns we use to treat cancer? Well, as a clinician, what we want to look at is the tumor of origin. Every cancer is different, be it a breast cancer, a lung cancer, brain cancer. All of these under the microscope look different. That's what pathology teaches us, how to identify the origin of where that tumor came from. Histology is exactly what it looks like under the microscope, because as every patient is unique, every tumor is unique. It looks different under a microscope, and we grade these from very well differentiated, meaning it looks like the original tumor, original tissue it came from, to very poorly differentiated, meaning we couldn't tell where it came from. It's just gotten so, the genetics of it has gotten so haywire, it doesn't look like anything, and it looks like just a very rapidly growing tumor. T&M is a staging classification that allows doctors to talk to each other. And it's basically the size of the tumor is the T, the N is nodal status, and M is it's metastasized everywhere. So every patient not only has a name to its tumor, a site of origin, but it's T&M staging, and that allows the doctors to separate apples from oranges, because every patient will be a T1, N0, M1, so it's a unique system, and we can compare how we're doing in treatment by the stage, because you can't say, well, I treated a stage 4 with this, regimen of drugs and chemotherapy and radiation, and it did better than stage 1. So you have to compare stage for stage, and this is what our studies look at, and this is how we advance the science of oncology by looking at similar patterns of tumor stage and sites of origin and compare different treatment modalities and how we do. Nodal status, again, the lymph node status, the N classification. Physical condition of a patient. You're going to treat a 90-year-old much differently than you treat a 30-year-old with breast cancer or lung cancer, or any cancer for that matter, because a 90-year-old is not going to be able to tolerate certain drugs, certain treatments. And you have to know the condition of a patient. And there's certain 30-year-olds that can't tolerate treatments because of poor heart disease, lung functions, things like that. So you need to know the physical condition of the patient. You've got to know what your treatment's going to do to the patient. Chemotherapy has a lot of side effects, radiation has side effects, surgery has side effects. So you have to know what your treatment morbidity is going to be before you can recommend to a patient a course of action. Cosmesis is what it's going to look like. Breast cancer, that's something we're very concerned about. We want the breast to look good after we've done a series of treatments to it. And again, we put all this together and we discuss this with the patients and help them make a decision what's their role or what's their path of treatment going to be. And again, we use prognostic predictive factors in breast cancer. It's your age, your tumor size, your grade, your hormonal status, and I'll discuss HER2/neu status in a little bit. We look at all this picture and tell a patient, well, the chances of you dying of systemic disease is 10% or 5% or 30%, and again, gives them some more information to choose whether they're going to have chemotherapy, radiation, surgery. So we put all this together to help them come up with a treatment plan. If you were unfortunate to live in the 1700s, this is how breast cancer was treated. There was no anesthesia, there was no sterile technique. You had to know someone who owned a knife like this, and he probably was a soldier or someone like that. Women with a big tumor, they would just lop this thing off and let this close. There was no sewing together, no general anesthesia, no real surgical techniques, and only 5% of women with breast cancer survived. It wasn't until this man, born in around 1850, Halsted, of the famous Halsted radical mastectomy. Halsted, books have been written on this man. He was a very fascinating character in medical history. Grew up in New York, went to Yale University, not a very good student, captain of the baseball team, captain of the football team. Parents were very wealthy, went to medical school at Columbian, was called Columbian Hospital for Surgeons in those days. Was really just a big, open, dusty room filled with people who had money enough to go to the school and try to become doctors. And he was fortunate enough to be able to hire his own private tutor, so he became a fantastic surgeon, one of the great surgeons of all time. Halsted not only introduced the sterile surgical technique where washing hands, gloves were used, he created the first residency program in this country in surgery. He also developed the Halsted theory of breast cancer, which was go get it. No matter where it is in that woman's body, I will surgically attack it. If I have to take off her breast, I will do that. If I have to take down to the lung, I will do that. If it's gotten into these into the patient's lymph nodes, I'll take her arm off. It was the surgical cure for breast cancer. Halsted had a problem. He and his colleagues were experimenting at the time with cocaine and using it as an anesthetic. Unfortunately, him and his colleagues became addicted to cocaine, and he went into a sanitarium for about 7 years, and the way they cured him was to get him addicted to morphine. So here was a surgeon, not only addicted to cocaine, but then addicted to morphine. His best friend from New York was a doctor named Walsh, who came to and started Johns Hopkins University's hospital. And this is the early 1900s. He came and became the chief of surgery at Hopkins, and again, initiated the operating room technique with sterile technique. And again, this is where he perfected the Halsted radical mastectomy. Again, these are a little gruesome, but very, very interesting to see. A woman with a breast tumor here, again, a very large incision, very disfiguring. Again, down to the chest wall, going into the arm, getting lymph nodes, doing anything it would to attack this cancer. And this is a picture, a very historic picture of a woman with a Halsted radical mastectomy. And as you can see, she's already got a recurrence here. But this man took 5% survival and brought it to 50% survival. No other treatment in the history of medicine to that time had increased someone's survival in cancer that much. So he really was a radical advocate for surgical technique or the surgical cure for breast cancer. In fact, it became ingrained in the surgeons so much that even up until the 60s and 70s, no woman would ever have anything but a Halsted radical mastectomy. Then they started working with a modified mastectomy, and then they started working with lumpectomy, just taking the tumor out and giving radiation. And it really brings us to modern day cancer treatment. The pillars of cancer treatment nowadays include surgery, chemotherapy, radiation, and usually a combination of all three. My field started about 100 years ago, 110 years ago, a man named William Conrad Röntgen, who was a physicist in Germany, experimenting at the time with what they called cathode ray tubes or the Röntgen ray tubes. All this was glass tubes, look like light bulbs, with an anode and a cathode, and it would pass an electrical charge through here, put different types of gases in here, put different currents of electricity through here, and the one side would smash electrons into the other side, into the anode, and this would generate beams of what they called X-rays. They didn't know what they were, but they were in love experimenting with these, and Röntgen was the first one to discover that it actually can pass through human tissue and show the bony anatomy. And this is the first known X-ray of his wife's hand, and this is her wedding ring. And if you can imagine any invention in modern medicine and the X-ray, where we are today, with MRI scans, CT scans, PET scans, you just name it, it is just a pillar of modern medicine is the X-ray. And this has only been around for 100 years. I just can't wait to see the next 100 years where our technology is going to take us. As soon as the cathode ray tube was seen that these beams had some magical effect on cancer where they would actually eradicate cancers, and they're usually used in a room like this, multiple patients being treated. Here's a cathode ray tube right in front of the patient's face, probably had some type of skin cancer on the face, and they would sit there for an hour or two and get bathed by these X-rays. In fact, their whole bodies were exposed. But this was pretty modern treatment for about 1905. As a matter of fact, today it is written in stone that taking the woman's breast cancer out, if feasible, and giving her radiation is equal and effective to mastectomy, not only in disease-free survival, but every parameter. And in fact, the consensus statement in June 1990 was this was a more appropriate method of treatment because it preserved the woman's breast. So nowadays, majority of women with breast cancer, and this is early stage breast cancer, will have what they call a lumpectomy, where instead of the massive disfiguring surgery, the surgeon will go in and take out the lump. Matter of fact, what we have here in Alamance, when we went to the first places in the state, they will also do a sentinel node biopsy, which is putting a little tracer in and finding the first lymph node in the arm that cancer would travel to, and biopsy that lymph node. And this is the conservative treatment. Now this is an old, just want you to remember, this is an old sort of, when I first got into radiation oncology, this is what breast treatment fields look like. We block out most of the lung and the heart, and this is the breast out here in space. And here's some clips on the lymph nodes, and this is how a radiation field, when I first started out, would look. And just wait to show you what we're doing nowadays. Today, if you came to Alamance Regional Cancer Center, we are a state-of-the-art, community-based, comprehensive cancer center. We've been so designated for 20 years, and this year we got 5 commendations, and which puts us in the top 5% of community cancer centers. We have, as I mentioned before, the Norval Breast Center.